second half. I know Dr. Dandapanimd just probably made your head explode because she is a fantastic lecturer and she lectures very fast and she has a lot of great tools. So it's a tough act to follow, I'll just say. My name is Nancy Metner. I'm the Neuroscience Program Manager. I have actually worked for Health First, I hate to say, for almost 30 years because I'm only 32. Started in SI for many, many years as the manager director, did a stint in quality director, then came back and I worked with Dr. Shaheen in the lab for 6 months. What a great experience getting to do thrombectomies. And then I've been here as a program manager for about 3 years. So we worked on a video. This is one of our patients that we did successful TPA and thrombectomy. We have a lot of our stroke patients that come back and they want to give back in any way it is, whether it's telling somebody their story, anything they can do. So this is Mr. McLaughlin and his family, and this is their experience that we reenacted.
It is the 5th leading cause of death and the 2nd leading cause of disability. A stroke occurs when the blood flow to the brain is interrupted by a blocked or burst blood vessel. Stroke patient care starts with patient comprehension of what symptoms they should be aware of. An easy way to remember this is the FAST acronym. That is F for face drooping, A for arm weakness, S for speech difficulty, and T for time to call 911 if you see anyone with these symptoms. Once a patient is evaluated by a paramedic and a stroke is determined, they will indicate a stroke alert, or code stroke, to the closest primary or comprehensive stroke center with the LKN, which is the last known normal time frame. The EMS team will then get contact information on the next of kin, start 2 20-gauge IV lines, check glucose level if possible, and perform a Van scale to identify if they are a candidate for a thrombectomy. The Van scale is an acute stroke screening tool used in the field to determine the severity of a stroke. It consists of checking the patient for arm weakness, visual disturbance, aphasia, and neglect. We will now show you the proper way to perform a Van scale assessment. In this demonstration, our clinician first asks the patient to hold both arms in front of them as she counts down from 10. As you can see, the patient displays arm weakness in their right arm, which indicates to continue. If no arm drift were present, the patient would then be considered Van negative. Next, the clinician begins the vision portion of the exam by asking the patient to look at her nose and reply with how many fingers she is holding up. She holds up fingers in 4 parts of the patient's visual field: upper and lower right, and upper and lower left. She then asks the patient to track her finger with their eyes, moving her hand across their visual field. In this case, the patient displays loss of vision in her right visual field. The clinician then performs the aphasia portion of the exam, which is the inability to comprehend and form speech. She asks the patient to follow 2 commands. The first, to close both eyes tightly, and the second, to make a tight fist. In this case, the patient was able to perform both commands. Lastly, the clinician performs the neglect portion of the exam to check for sensory deficits. She uses a small object to tap the patient on both arms and legs, asking each time if the patient could feel it. In this case, the patient could not feel with her right arm and leg. Since the patient displays symptoms in addition to arm weakness, she is diagnosed as Van positive. If the patient displayed arm weakness but showed no other Van symptoms, she would have been diagnosed as Van negative. Once the patient arrives at the hospital, the emergency department team will quickly evaluate the patient with a blood glucose test, a 12-lead EKG, CBC, BNP, PT or INR, and PTT. The nurse will then perform a NIHSS assessment while the physician screens the patient and updates the neurologist. If a neurologist is not on site, most hospitals have the capability to provide telestroke care through a Skype-like service. This allows the physician on site to relay information to a neurologist and ensure proper stroke care. There are two types of strokes, hemorrhagic and ischemic. A hemorrhagic stroke occurs when a weakened blood vessel ruptures. This is usually caused by uncontrolled hypertension. An ischemic stroke, which accounts for 87% of all stroke cases, occurs as a result of an obstruction within a blood vessel supplying blood to the brain. Both types of strokes are detectable through a non-contrast CT scan. During the first 3 to 4.5 hours after stroke onset, patients are eligible to receive recombinant tissue plasminogen activator, better known as TPA. Patients who receive TPA statistically have a 30% more favorable outcome with minimal or no disability at 3 months. Those eligible must be over 18 years of age, have a last known well time frame less than or equal to 4.5 hours, no bleeding indicated on the CT scan, and patient and or family should understand the potential risk factors. The patient is then taken to the angiogram suite, where the neurointerventional radiologist will perform a thrombectomy. A thrombectomy is a type of surgery used to physically remove the clot from the blocked artery or vein. The CT angiogram shows the clinical team where the blockage is located, while the CT perfusion will detect what tissue is salvageable, the penumbra, and what is infarcted. This is done by injecting dye to show which areas of the brain are adequately supplied or perfused with blood and which are not. The penumbra is the zone of reversible ischemia around the core of irreversible infarction. In an effort to save the penumbra, the first few hours of an ischemic stroke are crucial. Once a patient is treated, the stroke care continues in the neuro ICU and neuroscience floor, with a team of trained professionals working together to provide guidance for rehab. Clinical trials such as ESCAPE, Extend-IA, Swift Prime, and Revascat, to name a few, have achieved approval of endovascular treatment and thrombectomy for ischemic strokes with or without IV TPA, if within 6 hours of the onset stroke symptoms. Prior studies have indicated a clinical advantage to performing thrombectomy within 6 hours of stroke onset, with decreasing clinical benefit as time to thrombectomy increases. After 6 hours from stroke onset, relatively fewer studies are available to aid in determining optimal stroke management with thrombectomy. In the DAWN trial, it compares stroke patients with a mismatch between their clinical deficits and infarct volume, treated 6 to 24 hours after symptom onset with thrombectomy plus standard care, compared to standard care alone. This study provides significant evidence supporting thrombectomy treatment between 6 and 24 hours after stroke onset. The treatment effect size is the highest out of any stroke trials to date, which suggests that the presence of clinical core mismatch is a critical predictor. Similar to the Swift Prime and Extend-IA trials, the current Diffuse-3 trial examines the window between 6 and 16 hours using CT perfusion. Endovascular therapy plus medical therapy, compared to medical therapy alone, was associated with a favorable shift in the distribution of functional outcomes and a higher percentage of patients who were functionally independent. The 90-day mortality rate was 14% in the endovascular therapy group and 26% in the medical therapy group, with no significant difference between groups in the frequency of symptomatic intracranial hemorrhage. Due to new studies and updated stroke guidelines, more patients are now eligible for crucial treatment that could save their lives. Whether you are a patient, family member, or first responder, it is important to watch the clock and pay attention to the onset of stroke symptoms.
Okay, so that was our first video. And again, our stroke patients, they're doing a tremendous amount of community education for us. So my passion is stroke emergency. Even though I did trauma for years and years, it's real easy when you're a trauma and you've got a great story when they call a unit about how you were out on 95 and what happened with the patient and, what happened en route. It's really easy to get help from a lot of staff when you have guts hanging out, any of these things. But if you have a patient that comes in and they have maybe just a little bit of aphasia or garbled speech, and you're trying to run a stroke alert, do you find it a little difficult to get people to come in and help you? Across the system, we find that's really hard. And we just think it's really education. People really need to see that, even though this is so much easier and it's more exciting, these patients often get better. Our stroke patients live with those disabilities the rest of their life. So our door to needle of, less than 60 minutes requires a really dynamic team. Trauma did a lot of work early in trauma, and they called it moulage. And what moulage was, Dr. Amami actually brought this to the trauma center, is every person that was in the trauma bay, they actually taped off the floor the area that they should function in. If that associate didn't have all the supplies that they needed within their box, then we weren't efficient in setting up the room. We weren't doing things right as a team. We were taking more time, getting things done. Can anybody remember codes before where whoever yelled the loudest got what they wanted? People were scared, they were yelling, there was no plan. It's very much, if you take like the moulage, and then we kind of just went ahead and applied it to our stroke alert process, our clot alert process that we'll go over. Everyone's got a role. Everyone needs to know their role, but be really great communicators with other people in the team. If we're going to achieve a door to needle in 0 to 60, and if you're at CAPE and you get TPA and you need to have a thrombectomy, how are we all going to work together to get that patient the TPA at CAPE, have first flight on the helipad, load the patient, get them down here right into INR? So those are some of the things that we're going to focus on. So the other thing is, sometimes these patients aren't always recognized right away. They come in as walk-ins. They don't know. They're having a little difficult, they just don't feel right. Maybe they got a little tingling in their arm. They don't know whether they slept wrong. Those are our kind of our difficult ones. We have to be detectives. We have to sometimes assume something is a stroke alert until we can prove it's not, because it's not worth risking the patient outcome for that. So what are we going to do? In a dream scenario, we would rapidly know that's a stroke. They present right away via 911 to our hospital, or in Palm Bay and Deer, they'll be walk-ins because we are not certified yet. They'll get their clot buster in less than 60 minutes. All their symptoms will be gone, short stay in the ICU and go home. But that's just really not what happens every day. So we need to create a really great team to achieve those results. One thing that we're doing across the system, and everybody needs to know where we are in this, Holmes Regional and CAPE are Joint Commission certified, but we're advanced primary certified. We can give TPA, we can do thrombectomies, Holmes does, but we're only primary stroke certified. So CCH is open for their Joint Commission window October 15th through January 15th. VIR is going for their first certification September 24th, and you may be in this room as part of the preparation. Holmes is going to go for thrombectomy certification November the 5th and 6th, 2-day survey. Palm Bay will go for primary stroke certification after the first of the year. So the difference is here, when you look at primary, then thrombectomy just means that we get certified for doing those thrombectomies that we're already doing. Comprehensive is all the same, except those centers do research. So those are the different Joint Commission certifications. And there are stroke-ready hospitals that can give TPA, but they are just a drip and ship right away. So there are 11 elements to become an acute stroke team. So you can read all this. So what is Joint Commission going to do for us? They're going to go and follow our patients from the time they roll across our EMS door to the time you're ready to discharge. They're going to look through the chart, they're going to ask the staff, they're going to ask you great questions. And our advice is talk about all the great things you guys do taking care of your patients and stroke patients. Our outcomes show it. We don't have any slides to show you our outcomes, but we do a great job taking care of our stroke patients. So to have an acute stroke team, we need to have, and these are best practices. So I'm teaching you kind of globally from American Stroke Association, what are best practices in stroke care? That is to have a dedicated pager. They call it stroke code. So we call it Stroke Alert here at Health First. And in the community hospitals, you all have iPhones in your departments, ER, ICU, PCU, lab, CT, radiology, and pharmacy. So that's how we communicate amongst departments when there's a stroke coming in. So best practice is pre-hospital notification. We meet that. So Holmes and Cape that gets EMS patients, EMS calls dispatch when they're in someone's home and they're calling this patient they feel has a stroke. We get a page. We get a second page when EMS says, okay, I've got an ETA for you, it's 10 minutes. So we on our side can be assembling our team and making sure that a nurse gets assigned to that patient. We're thinking that through, I gotta get my TPA, I gotta get my forms out, I gotta be ready for this patient. The third page is when they hit your registration, and that's when you'll get the ER room that the patient's assigned to. And the fourth page is after the ER doc has done a real cursory assessment, whether he cancels or continues the stroke alert. We may cancel one at the door because they did a blood sugar and the blood sugar was 20. Well, they're hypoglycemia. Maybe it was like a complex migraine, a UTI, something that they could assess right there. You may get a cancel. So we follow best practice. They want to see an ER physician at that patient's bedside in 15 minutes. Across the system, we are there in probably 5 minutes, and sometimes we're there before that. So we do great. We need to have written protocols for IVTPA and the blood pressure management after. And then this is just the base team that Joint Commission requires. So a stroke neurologist, ER physicians, nurses, radiologists, techs, and a pharmacist. That's your core team that Joint Commission says you need. Now, stroke neurologists, we know at Holmes we have neurohospitalists that respond to the stroke alert right there. In the community hospitals, you all have telestroke. And that is how we meet this expectation of Joint Commission. And there is more and more telemedicine, as you all know, across the system to meet our needs. So again, that's the core team, but as an expanded interdisciplinary team, we have all these different people, rehab, the lab, IR, quality and outcome department to measure our outcomes, case management, social work. And it's really important for a team, everybody knows their role. And I always use this example. If you're in a code, rapid response, or a stroke alert, what can bring it to a screeching halt? That your HUC doesn't know how to call transfer center and page out an alert. Sometimes it's the little things that we need to do to educate. They seem basic, but it can really extend your times if you're waiting for rapid response to show up, only to find out that your HUC didn't know how to call and page out a RRT. So know your role. Again, our facility partners with EMS on everything. Again, we went over, they call stroke alerts in the field. They let us know on the page if they get an accurate last known well. It's on your pager. You know that before they get there. So last known well, are they going to be in the 0 to 3 TPA window, or maybe an extended 3 to 4.5 hour window? Some things that are happening across the country, Dr. Dean and I always go to the national conferences. Some people are even doing telemed from the ambulance, and who's videoing in is their INR physician. So they're already doing things like getting consent and doing their assessment, that physician is doing it while the patient's in transport to the hospital. So they kind of went over VAN, and we saw that in the opening video. Just what I want to point out though is since we started doing VAN assessments, if you didn't have a VAN, studies show that it could take you 120 minutes to get from arrival to the hospital to the INR suite. Once we did the VAN assessment, we knew that patient was probably going to be a candidate for INR. We were able to cut that time down to 60 minutes with that early assessment and communication. I'm going to skip the VAN training because we did it on the first video. You pretty much saw everything there. So again, best practices is just knowing when there's a stroke alert coming in. Best practice also says that EMS can take the patient to CT and the nurse and physician meet the patient in CT. So we do, Cape Canaveral actually does that at the back door of the ambulance bay. Their physician and nurse meet the patient and do the assessment. So the other hospitals are still going directly into the ER room, but very readily that team is in there doing the assessment, labs, EKG, and getting that patient to CT. So here, what do we do when that patient comes in through the back door? What are our priorities? What do we have to do very rapidly? We need to have phlebotomy drawing the labs. Not to say that nursing can't. You can and hand them off to the phlebotomist because they should be coming to your stroke alert. But if it takes one thing off your plate as a nurse because you're managing everything else, let phlebotomy own that piece and label and then take either tube or walk them to lab, whichever your hospital does. So what assessment things does the nurse need to do? They need to do an NIH. The swallow screen, get the CAT scan first. I just put it in here just to make sure we do a swallow screen and get an accurate weight. Make sure that you know where your stretchers are that have the scales because you need accurate weight so you can dose your TPA. And you don't want to be on the scanner to find out that you're going to give TPA and realize you forgot to weigh your patient. Because you'll have to take them off and put them on it. It's not a good way. So again, what are the other priority for TPA? Alteplase. You're going to be helping with the inclusion-exclusion criteria. Again, we're detectives. You're doing it along with either the telestroke neurologist or your neurologist at the bedside at home. Medications, trying to get that med list. A lot of times social work comes to the stroke alert and they can go into the different pharmacy website where you can pull their med lists. So a lot of detective work going on. And then once you do, like I always tell people, this is stroke alert. From here to here, stroke alert. You know, that is to TPA determination. You are a clot alert once you're in CT and they see on your CTA CGP that you have what? A small core, big penumbra, right? Save the penumbra. Once you're identified as having that clot, we repage that out as a clot alert because I'll show you on the algorithm that lets a whole new group of people know to get activated to help get that patient for a thrombectomy. So positive large vessel occlusion, last known well, less than 24. What were the two studies that proved that? Dawn and diffuse study were the two studies that proved that. You need to make sure that you have 18 gauges. And then INR likes to know their GFR before they go into the lab. And you need to have a physician order. So when Chandra and I go across the IDN, we try to do mock alerts. And what we did is we developed a tool to help the nurse understand how fast they have to do everything, but just give like a time frame. Okay, in that first 10 minutes when that patient comes in, you know, we need to identify the signs and symptoms. If you are on the floor inpatient, you'll call RRT. If you're in the ED, you're notifying your emergency room physician you have a stroke. Last known well, and then make sure you have your adequate IVs started. Usually EMS starts one, you need at least 118 to get you, so if you have to do a CT or CTP, your accurate weight, place the patient on the monitor. So really 0 to 10 minutes, you can see how many things you have to get done. So the 10 to 15 minute mark, you should be headed to CT. Your NI should be done. At that point, if you are in a community hospital, you'll be putting in your telestroke alert. And then the 15 to 30, you have your imaging done, CT, CTA, CTP, if it's so indicated. And then what if you have your alteplase? What should you always bring with you? You should bring your TPA with you. Holmes definitely gives all their TPA while the patient is still on the CT. We're working towards that in other hospitals. When you do the TPA, we'll go over that. We're on the list. We're looking to validate the dose, mix, administer, and start your vital signs and neurochecks every 15 minutes. So you will see us out there doing these mocks. If anybody wants to be involved in a mock, because they know they're going to be there the day of survey, come to us after the class. We'll make sure that we get you scheduled so you can be involved in the mock. Because day of survey, the best thing that can happen for us is that we have a stroke alert first thing, and the surveyor just watches you all do a great job doing a stroke alert, and then, survey goes well. So again, you're in CT, you're determining if you're got an ischemic or a hemorrhagic. So what if you had a big bleed? Then we just get a neurosurgical consult and then transfer. If you're at a community hospital and you have a large bleed, you're going to transfer to Holmes for care. So in the emergency room at Holmes, we have two algorithms, okay? So you come in via EMS with your stroke alert, right? And you're in a 3 to 24-hour window. We're still going to call you a stroke alert. You're going to go through and do everything we just went over on the, your labs, your CT. You're going to do all of that. Then, let's say, you're going to get your TPA, so door to needle of 60 minutes or less. That's what we're trying to achieve. And then, let's say you have that clot. You're going to call the clot alert. That second page lets anesthesia know because they're on standby for all the cases. So as soon as they get that clot alert, they're getting ready because they know they have an INR case in less than 30 minutes. The SI nurse needs to know because they need to assign a bed. And what the SI does for us, and this is just a process thing of how we try to cut time down, they print the armband, the face sheet. They meet the patient in INR, and they do that band-to-band change if it came from a community hospital. They would verify that. EICU needs to know because they're going to manage the patient. The neurohospitalist knows because the next day or that night they will consult on that patient. It lets our INR team know to come on in or that they have a case. So that is our clot alert, from stroke alert to clot alert at Holmes. So for everyone in the community hospital, the piece that kind of changes is here, once you guys page a clot alert, then you guys just have to call transfer center, and that patient will either be picked up by a first flight or ambulance. And one thing we noticed as a system, we had a couple patients come in via ground, and there was some confusion in the ambulance bay. I mean, the nurse is coming from a community hospital, never been to Holmes. You get dumped into our huge ER at the back door. And they were right. They didn't know where to go. What were they supposed to do? So now what we do is I ensure that security is on standby. They meet the nurse and the patient at the back door, and they will escort the patient to INR. At that time, they'll give a report. The SI nurse is down there to help band the patient, help move the patient under the table, because every minute counts. So this is how we coordinate all of our resources to try to get door to needle less than 60, and then it's from picture, what we measure, picture CT scan, to puncture of the groin, to reperfusion needs to be 120 minutes. So those are our goals. So if we kind of go back to TPA again, who's going to be eligible? In the 3-hour window, that is gold standard, okay? You don't need to have a consent for that. I know CCH does still do consents for the 3-hour window. Their medical staff likes that. They want to keep it that way. So, but you do technically not need a consent for 0 to 3. You do need a consent for the extended window because you have a higher risk of bleeding. So there is a specific consent. It's in the neuroscience form fast tree for you. We did have some updated guidelines in 2018 at the International Stroke Conference, They've removed the age. They used to have an age limit, 80 on TPA. They've removed that. They've removed the NIH. You can still give TPA for patients that are also having seizures. So here too, elevated blood pressure, there's no set amount. You can treat the blood pressure. As long as the blood pressure is under control, you can go ahead and give the TPA. The other is patients not taking warfarin if their INR is less than 1.7 or on any other anticoagulant regardless of INR. And then we just have the extended window. So here, again, trying to save the penumbra. When you are rushing to CT, what they're doing is they're looking at that mismatch, that cord penumbra. So when you're in CT, first radiology needs to read it. So you may go back to the room because you're pending that result. But again, I know Dr. Dean went over those. You know, these are the patients that we really need to expedite getting transferred. And I will say, so it has been disappointing sometimes. We've actually transferred patients, but within the time frame, you know, well, it was actually before community hospitals did CTA, CGP, and we got them here and did it, and we found that they had this huge core and we couldn't help them. So that, as a stroke program, that's one thing we changed. When you stand in the hallway with Dr. Shaheen and a patient and their family, and you have to tell them that you're sorry, it's too late, you've now done the imaging and the core is too big and they have too much dead tissue. And, you know, even I have even seen Dr. Shaheen tear, trying to tell family that it's too late, you should have come in sooner. So we are always trying to improve our program. So again, what we measure for thrombectomy capable is from picture to puncture, and then we also have to then include transfer times for our community hospitals. So these are some of the different devices. We saw the videos of those. And then this is just globally across the country. So you can imagine now when we extend the window to 24 hours, what that did in one lecture, it made every hospital have to figure out how they were going to meet those resources. We were only treating patients with less than 6 hours for INR valves. Now going out to 24 hours, it's really tough. If you've seen Dr. Shaheen, you know he's a little tired. We're getting him some help. So what we need to do is we need to make sure that we have dedicated neurointerventional technologists. That means we want to on-call at night, and then the ability to deliver the care. We meet all those expectations for our upcoming survey. And again, in our room during the day, we have a physician. We do not have a scrub tech. We have cross-trained our nurses to be scrub techs in our lab. So you'll have a tech, a physician, and a nurse. So during the day, you'll have 2 nurses. At night, you have a smaller call team. So again, globally, we are looking, we need to make sure we get those patients to INR as fast as we can. We monitor our results to make sure we're consistent with our times, that we have adequate reperfusion, and that we use a TP3 score, and that means that the vessel is opened up at least 50%. So those are things that we measure. So again, we've gone over these: large vessel occlusion, small core, big penumbra. And again, these are how tiny the clots are. I mean, it's amazing what we see. So the only way that we can get this 120 minutes from, you know, picture to reperfusion is to make sure we have a collaborative IDN approach. If we're not communicating with your staff out in the community hospitals, there's no way we can efficiently get those patients to homes straight to the door of INR and get them what they need. So again, I always say here, we need to build bridges to accommodate, you know, getting our result, but also once we become primary stroke certified at Vieira and Palm Bay, our volume is going to explode even more because we lose a lot of stroke volume to outside facilities. So this is just a picture with inside our lab. Oh, okay. So this is kind of cute. I just have one little story. So has anybody here been a nurse long enough to know what a gonko is? Oh, please, somebody raise their hand. Okay. So it's like this little suction machine. You see them on the code cart, right? So believe it or not, in the lab, there is a piece of equipment that sits on the foot of the bed of the INR lab, and it's called a penumbra, that's the name of it. It's a gonco. And what we would do is we would thread in the wire and everything, and we would actually turn on that suction. And you do it on and off for about 5 minutes. Once the retriever was in, like this, so we would suck all the blood around there, the little microclots we would get out, we'd suction it just like through a gonco. Then we'd wait, and then we would pull out this clot. And I'm telling you, I saw so many great cases. One that was fantastic was 2:30 in the morning, this little gentleman that only spoke Spanish. So again, he's agitated, he can't understand. Dr. Sheen spoke like 2 words of Spanish more than me. But anyway, he's agitated, we're trying to communicate with him, we're trying to get him on the table, we're working as fast as we can. We put in the catheter, I turn on the penumbra, we're getting all the clots out, and then he goes, okay, we're pulling out. And so he starts to pull it out. Now, you have to imagine, we can see that on the big screens in the room, okay? We can see that wire catheter coming out of the brain. By the time we pulled it out and we got into the carotid, that man started singing in Spanish at the top of his lungs, beautiful, and serenaded us the rest of the entire case. That's how quick it was getting that clot out of the brain. So really fantastic results there. So post-cath care, really just looking, just like any kind of cardiac cath, you're looking for brain management, clots, and making sure you keep your blood pressure within control. So quickly touching on this, we also have hemorrhagic stroke care. We really talk a lot about ischemic, but SICU at homes does the ventriculostomy. So if you had a patient that had cerebral swelling, we do ventriculostomies here. We put them in at the bedside, one of my favorite things to do. And because I always try to test to see how high the ICP was by how fast the CSF shot out of the end of the catheter. That's pretty good. So anyway, we do provide that care in SI. We have 3 neurosurgeons here at home. So again, when we talk about intracranial pressure, we have to just real quick know that this is a fixed box. You can only have so much swelling, so much blood in one little thing, and you've got to relieve one of them. So one, we're either going to remove CSF and see if our ICP comes down, or what we do sometimes is a hemicraniectomy, where they actually take a big bone flap off, let the brain swell outside the skull. They put the skull in the tummy until the brain swelling goes down, and then they put it back in. So again, it's just pictures of patients that have had the brain swelling. So for now, we're going to start doing our TPA. Now I know, how many PCU staff do we have? Okay, I know we have some of you. Really think though, your patients are also going to ask you if they've gotten TPA and a little teaching. So I know we're going to go in detail, but it's not lost. You'll be able to really help, teach your patients after they've had TPA. So, sure, you guys feel like you want another break, or you want to go right into TPA? TPA? Okay.
Who's mixed TPA already and you're ready for patient? We ready? At each hospital, you should have a binder. If you work at homes, you have a binder in each pod where it should have these in there. If you work at the community hospitals, in the telestroke cart, there's a binder. You should have these, and then on the ED and ICU units, you also have some pictures. But if you need more, please feel free. If you want your own, come up here and take it. This is our Bible here at Health First for mixing. Remember, giving out a place to a patient in a stroke alert is an emergency. You do not have to wait for pharmacy to verify it. And there is a policy also in each of the pods at homes, in each of the telestroke cart binder that show you that you can administer this, mix and administer with another nurse verifying in an emergency, okay? Because I get that asked a lot. Any questions on that before we go over the process? Anybody have any questions? Okay, so just know that. The first thing on the steps, it says that you need to make sure the patient is weighed. And for those of you who work in-house, like on the in the ICU, even if there is a weight documented already in SCM, you are not to use that weight. You have to weigh that patient. The patient have an actual weight done. And that's the first thing. Remember, this is a weight-based medication, so there are 2 times while verifying this medication that you can make a mistake on one. The first one is with the weight. So just remember that you are going to weigh your patient. You're going to print up the worksheet like it says on the instructions. And you're going to go to your Pyxis and get the medication. You should be able to override it. At homes, there is a launch pad. There's a Pyxis in the D-side CT scanner that you have 2 doses of these. It should be in a kit like this, so if you go back to your unit, those of you who work ED-ICU and it is not in a kit, we need to let your pharmacist know immediately. Because in here they have the medication in a box, they have a couple of syringes, IV flushes, and IV tubing for you with an 18-gauge needle. So it comes in the box, it looks like that, 100 milligrams on the outside. You're going to override it. There are 2 bottles in here, 100 ml of sterile water, 100 milligrams of powder. There is a dual spike. Again, you're going to print your worksheet, and on the step it tells you, if you go to SCM, on the top of your screen it says tools. You scroll down to Activase worksheet. Page will come up that asks you to put in the patient's weight. You put in the patient weight and hit calculate, and it will calculate the whole dose for you. So one rule to remember, this medication, the maximum dose a patient can have is 90 milligrams. So in here you have 100 milligrams of powder, 100 ml of sterile water. It's a 1-to-1 concentration. That means you're always going to have a wasted amount, right? You're always going to waste 10 ml. So for every patient that weighs 100 kgs, which is 220 pounds, or over, they get the maximum. That means they'll get 90 milligrams. So for those patients, you'll waste 10. So to reconstitute, this is pretty easy. You're going to use, have gloves on, use your aseptic technique. There's a dual spike in here. You're going to take it out. Make sure you spike the sterile water first. So you're going to go ahead and spike that. And then you put the powder on top. And you just flip it over and let it reconstitute. You can gently swirl it. Don't shake it out. Because if you do, you'll have a lot of bubbles in the tubing, and also you can damage the protein. So it's already mixed. When it's already reconstituted, you'll have 100 milligrams, which is 100 ml, and then you will follow the instructions on this card. So on the day of your survey, if you happen to be working and the Joint Commission server is following you around, and you are mixing out, please make sure you have the card. You should do this every time with a second nurse, and both of you are going through the steps, step by step. The first thing on here, it says, print out the Activase Alteplase worksheet from SCM tools, verify patient weight is correct, and keep the sheet because that will be your handoff tool. It's not a permanent part of the patient's record, but for those of you in the community hospital or even the ED at homes, your patient may end up going to INR, and everybody's going to ask you, right? The nurses that you're going to give a report to, the INR team will want to know how much medication the patient gets. Any questions on any of that? And so now, if you've watched the Genentech videos in the past, they teach you to go directly in on the top of the bottle, put your needle in there and remove the wasted amount. The problem with that though, when I've actually been present when this happened at homes, if you are wasting, let's say 40 mLs out of here, it means how many times you have to stick the top of this bottle. Maybe like 4 times, right? And then you still have to pull the bolus. So by the time you go to prime your tubing, guess what happens? It's leaking everywhere. Do you know how much this medication costs? Like $8,500. So my manager, Nancy, she researched what other people were doing, and we found on a YouTube video somewhere that they were directly priming their tubing, the primary tubing in here, going to the last port, the port closest to the patient, and slowly take your time and pull your waist. Remember, when you pull the waist, you're not going to put it down, and then pull the bolus and put it down, and then remember which syringe is the waist and which is the bolus. You're going to pull it, you're going to discard it immediately, what the amount that you're going to waste. That will be a joint commission question. What's the first thing you do after you reconstitute the medication out of place is you are going to discard your waste. Any questions on that? Okay. So you already waste. Now you pull whatever your bolus amount is. You're going to give it to the nurse who's helping you to go ahead and push it over 1 minute. But before you do that, you have to start the neurocheck and vital signs for alteplase. So the neurocheck and vital signs for alteplase starts with the bolus. So while you're mixing, you can go ahead and get a set of vital signs, get the blood pressure going. But what happens if the blood pressure is too high?
Remind me later.
It's reminding me. Vance, thank you so much. So what I did for you guys, because in doing my tracer preps around all your units, and I'm asking nurses, what are the blood pressure parameters? What should a patient's blood pressure be before alteplase, after alteplase? And I've been getting different answers. So went ahead and made some cheat sheets for you guys. I have a lot of these. I'm going to pass them out in your unit. I've emailed it out to your managers, so you can have it handy and you know what the blood pressures are you try to meet. So before you give patient alteplase, the systolic blood pressure should be under 185 and the diastolic under 110. So that means, remember that you saw Nancy explain to you guys that they've taken high blood pressure is not a reason not to give the medication anymore, right? You just have to treat the blood pressure and then we can still go ahead and give it. So this is why it's so important that you guys get a blood pressure right before you push that bolus. Because if the systolic, let's say the patient's systolic is 190, diastolic is 110 or 112, you are going to not give the bolus. Maybe let the physician know. If you're an ED, get an order for something, maybe labetalol usually is what they order quickly. Treat the blood pressure, recheck it, and as long as the systolic is now under 185 and the diastolic under 110, you can go ahead and give it. That is a reason to document a delay. So I also have some other cheat sheets for you. I have a reminder of documented reason for alteplase delay. So you've pushed the bolus, right? And you hung your drip and everything's going well. And at the next 15-minute mark, the patient's blood pressure is now 184 over 110. What should a post blood pressure be? On here I have that for you. Once you've given TPA and started it, the blood pressure has to be systolic less than 180, diastolic less than 105. Okay? So for the next 24 hours after you start TPA, the patient's blood pressure should be under 180, under 105. Joint Commission is really strict about vital signs and neurochecks during and post alteplase. And they look at every patient's blood pressure for the next 24 hours. So if the blood pressure spike anytime during that 24-hour period, you have to, make sure a physician know right away, or if you have medications on order, that you are addressing it. Any questions on any of that? Usually I get asked questions, what is considered neurochecks? So neurochecks during TPA is you're reassessing whatever symptoms they came in with. Let's say your patient, for example, had right-sided weakness, facial droop, slurred speech, aphasia, and a visual field cut. Peripheral visual loss on one side. It's easy to document all the other symptoms. Where are you going to document the visual field? So very good. Did you hear that? Comments. So you don't have to go make your neuro assessment longer than your NIH, right? What you can do, some nurses say, should I do an NIH every 15? No, you don't. Can you imagine doing an NIH Q15 during administration, then Q15 for 2 hours afterwards, and you're never going to leave your patient's room. So do a focused neuro assessment on their symptoms. Where are you going to document sensory loss? But those are the ones you don't find, right? So this is what you do. You can do on change to your basic neuro assessments, and then just add those focal deficits that the patient have. And for example, you can say no change in visual field loss and sensory deficit. Does that make sense? Yeah, so just make it easy for yourself. I can tell you a story. The other day I was at Cape Canaveral Hospital. This patient came in with dizziness, 55-year-old guy. He was at work. He suddenly got dizzy. It was around 11:30 in the morning. And he also had some blurred vision. Well, they didn't stroke alert him when he came through the door, but the ED nurse did an NIH on him. His NIH was 0. They did a stacked CT scan of the head. They're working him up for other things, did labs. He came back to the room about a couple hours later. The ED doc's trying to decide, should we admit him and just work him up overnight for something? Well, nurse went back in the room, and now she's asking him questions. His speech is slurred, and he can't remember, like, the questions that she had asked him before that he answered fluently. So what would his last note normal be? Very good. I'm so proud of you guys. When she did the NIH of 0, when she did that NIH, so we stroke alert that patient, and he got TPA. Was there a delay? The ED doc had to document a reason for delay. Immediately after he got the bolus and the drip was hung, everything came back except the visual field deficit. He was transferred home to the INR lab for a diagnostic, CT perfusion. Well, when I went to see him in SI the next day, and his visual field deficit was completely gone. He was back to normal. He could not thank me enough. He said, I really want to thank everybody at that hospital who took care of him. Because it happened right in front of their eyes like that, and he recovered quickly. So that's how fast this medication can work. But that last known dwell time is really important. So if your patient come in, and I think on one of my slides I'm going to talk about doing a neuro assessment on your patient and doing an NIH on admission, especially for those patients who come in with the vague symptoms. You know, the ones that you're not sure they should be stroke alerted, but they don't look right, they seem to have everything all intact. Do an NIH on them, even if it's a 0, because you know what, something happened an hour or 2 later, we give this patient a chance to get out of place. If that nurse did not document an NIH, his last known his dizziness started, he was having that all morning at work. So what would be the last known well time? We wouldn't know, right? And a lot of neurologists are very, they're very careful in administering this medication if they don't know for sure what a patient's last known normal is. So we have to have that documented. Any questions on the process? I have a lot of cheat sheets for you, so feel free to come up and get it. Documenting reasons for delay. We as nurses do a lot of documentation. Unfortunately, for this piece, it needs a physician to document the reason. So you all are at the bedside, you know what you're doing for that patient, you know what the reason for delay is, right? Please remind the physicians to document it. And I had a physician ask me at Cape Canaveral the other day, so what is the time frame for documenting delay? So what is our door to needle time? Okay, door to needle, stroke alert call to TPA, 60 minutes. Even if it's 61 minutes, they have to document a reason for delay. This metric gets reported to the Joint Commission, get to the guidelines, which is a part of the Joint Commission. And when they come to evaluate, like Holmes and Cape Canaveral for recertification, they're going to look at our door-to-needle time. So we have to say we're meeting their standard of door-to-needle time 50% of the time. So the ones that we have documented reason for delay, those get pulled out of the numbers. That is why this is so important, just so you guys understand why we are doing this. Any questions on any of that? And up there, I don't know if you can see that, but remember, blood pressure management, even if you have to give your patient 1 dose of labetalol, how long does it take for you to go to the Pyxis, get the medication, draw it up, and give the patient? Maybe 2-3 minutes, if you're fast, right? Is that a reason for delay? What if your door to needle is 63 minutes? Hey, I had to stop and give labetalol. That is a reason for documenting. And you know, is anyone going to question the doctor the reason they document delay? No, but they will question us, the nurses, right? Invasive procedures. What if I had a case at Holmes? I was in an ED with this poor nurse who she tried so hard to get an 18 gauge in her patient. They were about to put the patient on the stretcher and a CT scanner, and the 18 gauge came flying out. So in comes the neurologist that's going to give TPA, and now we have no IV site. Is that a reason for delay? Yes. So the doctor needs to document that. So you guys are there, like again, you are eyes and ears, you're at the front line, you know what's happening, you know where the delays are, just make sure it's documented. How about locating family members? I've had cases where the patient doesn't really know what's happening, everything is happening so fast, and they don't want to agree to get the medication. I want to wait until my wife gets here, or whoever, my son. Because I'm not sure what this all entails, I just want to wait for them to get here. That is a reason for delay. The other common reason I see a lot of is the time it takes the teleneurologist to explain the risks and benefits to the family and the neurologist at home. Sometimes the patient or their family have questions. And normal, video conference with the family should take under 10 minutes, but there are times it can be 15 and 20 minutes. The time is taking the teleneurologist to explain to the family, and the same thing for the neurologist at home. So those are all reasons, valid reasons for delay. And I have these cards, I have a ton of them if you want. See me after, I can give you one.